Hi, I'm Bjork, Executive Director of Lymphatic Education and Research Network, and I just want to take this opportunity to thank all of you for joining us today for our Symposium series. I also want to take this opportunity to thank all of you who have become members of LE&RN and help support this series so that we can continue bringing this kind of groundbreaking information to you in your homes and offices. I would also suggest for all of you who have not become members of LE&RN, $5 a month, you can become a member of LE&RN and help support this programming and the research that we do. Thanks very much for joining us, and I look forward to having you become a member.
Hello, everyone. Thank you for joining us. We are live for the Lymphatic Education and Research Network Online Symposium. My name is Robin Bjork. I'm a physical therapist, a certified wound specialist, and a certified lymphedema therapist through the Lymphology Association of North America, and also a certified lymphedema and wound therapist through the International Lymphedema and Wound Care Training Institute. Today, we're talking about wound care and lymphedema treatment, an exciting topic to explore the synergies, pitfalls, and pearls for success. So thank you again for joining us. I'm really excited about this webinar. I'd like to recognize our prestigious sponsors of the 2017 LE&RN Symposium series. This is made possible by the generous support of the following sponsors. By way of disclosure, I am owner and CEO of the International Lymphedema and Wound Training Institute and an employee of Sigvaris as Director of Innovation and Medical Education. I'd like to jump into a patient scenario that to me is a model of what can happen when a patient falls through the cracks of our medical system where wound care and lymphedema treatment are not looked at as a cohesive treatment plan. This is an overview of a patient that I met in 2015. She's a 60-year-old white female, 5'2" and 349 pounds, no history of CHF, chronic kidney disease, peripheral arterial disease, or deep vein thrombosis. Within the period of 2003 to 2015, she had a 12-year history of chronic progressive edema, recurrent venous leg ulcers, recurrent cellulitis with one hospitalization, development of massive medial knee lobes, slow progression to significant disability, and limited mobility. Her past treatments included edema and bouts of cellulitis, initially treated with diuretics, IV antibiotics when she was hospitalized, and extended use of oral antibiotics, multiple courses. She was also prescribed bed rest and leg elevation. Between the dates of 2005 and 2015, she had recurrent leg ulcers treated in the wound center with topical wound care and Uniboots, which were applied to the knee only. 2006 and 2013, she had 2 short courses of treatment by 2 different lymphedema therapists with limited manual lymphatic drainage, either no compression or compression to the knee only. And by then, I'm guessing it was very difficult to bandage because of these massive knee lobes. And there was no long-term compression plan or home program that was established. In 2008, she did receive a free pneumatic pump, but this was applied with no instruction or follow-up because it was free. And also, there was poor closure of the pump garment. And it did not snug up at the thigh portion, so it kind of hung open, and therefore she really only got compression to that medial knee lobe as well. When we look at this patient's clinical presentation, we can see 3 main types of edema at play here, which we would call in combination phlebolymphedema. This is a combination of chronic venous insufficiency, lipedema, and stage 3 lymphedema. Let's take a look at chronic venous insufficiency first. What are the signs and symptoms that would be indicating to us right away that this person has chronic venous insufficiency. One of the classic characteristics is hemosiderin staining, which we're going to talk about a little bit more in a few minutes. Abnormally dilated veins along the ankle, corona phlebectactica, which you can see here, and recurrent venous leg ulcers, which had been treated in the wound center on a recurring basis. Let's look at the underlying pathophysiology of the chronic venous insufficiency. What's going on here? Well, normally our calf muscle would augment blood flow through the veins back to the heart. When the calf muscle contracts, it puts internal pressure on the veins and propels the blood forward, and healthy veins with properly working valves will prevent backflow of the blood. But when a vein becomes incompetent, that valve gives way. It causes regurgitation of this blood, a lot of back pressure in the venous system and the capillary bed. The vein walls can become stretched out and incompetent, as pictured. What happens is in the upper right-hand corner here, you can see that normally our red blood cells would go through the capillary bed in single file and stay in the capillary bed. But when there is a lot of back pressure in the venous system because of chronic venous insufficiency, this pressure can become very high, causing and forcing these red blood cells out into the tissues, where they essentially fall apart and release hemosiderin, which is an iron stain or a deposit in the skin. And this results in hemosiderin staining, which you can see in these pictures. This is a classic clinical sign of chronic venous insufficiency. So when you see this hemosiderin staining, you know that there's an underlying chronic venous insufficiency in conjunction with whatever other medical conditions you're treating. Other CVI characteristics that are commonly found in patients are varicose veins, distended medial ankle veins, venous leg ulcers, which are shallow, draining, and painful, and lipodermatosclerosis can be found, which is basically, it ends up, the leg is shaped like an inverted champagne bottle. Okay, so you have scarring and fibrotic tissue changes in the ankle, constricting the ankle, and then you have a lot of swelling and a larger presentation of the leg above it. Now, in the patient case scenario that I was showing, you didn't see this because of the concurrent lipedema, and then also we had the secondary lymphedema going on. One thing I find very interesting is that even back in 1994, studies were showing that CVI and stasis dermatitis resulted in lymphatic capillary lumen collapse and derangement of the anchoring filaments within the lymphatic capillary network. And in 2016, you can see this very interesting slide that even in an area where there is just hemosiderin staining, which we just talked about, there is this diffuse presentation of lymph flow indicating focal lymphatic capillary damage. So oftentimes, whether a patient has just CVI or they have lipedema or lymphedema with concurrent CVI, you will end up with a diagnosis called phlebolymphedema. This is a combination of CVI plus lymphedema. Now, in the case scenario pictured here to the left, you can see that primarily here you have chronic venous insufficiency leading to a secondary lymphedema with swelling in the toes and feet and a lot of fibrotic changes in the tissue. Versus in this case scenario over here, it looks like more so the lipedema has a component of poor connective tissue support of the vasculature, and it may just be concurrent chronic venous insufficiency, which is developing in this patient in conjunction with the lipedema and lymphedema. In this case, then, you have recurrent venous leg ulcers in combination with the other types. The second piece of this clinical presentation is lipedema. So let's briefly talk about what that is. Lipedema is a painful fat disorder or painful fat syndrome, and there's a plethora of information, fatdisorders.org. I really encourage you to go to this website and read up on this condition. We're going to briefly highlight some of the features that were found in this patient that alert us to the fact that the patient has lipedema. One is this loose, lobular, fatty tissue with disproportionately large hips and thighs. The characteristic inverted shelf at the ankle, and the relatively spared feet. So this configuration of the lower leg is very commonly seen in a person with lipedema. And it's very common also to get lymphatic congestion in this most dependent area, and you can have even more of a pronounced inverted shelf or almost like a mushroom configuration at the ankle. The next aspect I want to talk about in this patient scenario is the stage 3 lymphedema, which unfortunately was never adequately addressed. What are some of the signs? She developed this massive localized lymphedema at the medial knee lobes, in part because this is where we have a large number of lymphatic vessels that converge across the medial aspect of the knee. When she had recurrent compression to the knee only, this exacerbated the fluid accumulation in the medial knee. Recurrent cellulitis, this is part of a patient's journey that has chronic lymphedema that is not addressed. And lymphorrhea with painful skin denudement resulting in partial thickness wounds. We're going to talk about what to do for this lymphorrhea in a few slides. Also, intertriginous dermatitis between folds, which will also go into further discussion as far as what do we do for treatment for this. As a quick overview, I like to think of the analogy of the lymphatic system as being a garbage disposal system. All those toxins, dead cells, bacteria, cancer cells, tattoo dye, perfumes, and chemicals that might be in lotions and things we smear on our skin. Normally, our body's continually purging all that stuff with this great flow of this lymphatic fluid that's bathing our whole body every day. We don't want to look like this sludge in the upper left corner here. When our lymphatics are not working, think of this picture. It builds up a lot of toxins and chemicals and things that are not supposed to be in our tissues. Secondly, a recycling center. There's things we want to recycle, right? Our blood proteins, and we need good flow of the lymphatics so that our white blood cells can alert the body that there's bacteria invading our body. So recycling the good things. And finally, a spillway. This is where the lymphatic system is critical in accommodating for the overflow of excess fluid in our body. Briefly, let's look at how does the lymphatic system, what's the pattern of flow? We start with the lymphatic capillaries, which is a 3D, very complex, interconnected web of lymphatic capillaries that don't have valves that are in the dermis of our skin. It's an amazing system where fluid can flow in any direction, but typically it drains one portion of the skin called a lymphatome. And here we have a representation at the capillary level. You see the blood flow coming in the arterial side, exiting the venous side of the capillary, and that's where our lymphatic capillary starts. It's a little bit bigger as far as the openings and the wall of the lymphatic capillary, so that larger cells and things can be circulated through that lymphatic system. This capillary network then drains a certain piece of the skin or piece of the body, and it drains into collectors, which basically collect the fluid from that area of the skin. And these collectors can be visualized here in this picture, and it looks a little bit like a string of pearls because each of these bulbular sections have a little contractile unit with one-way valves at this point called the lymphangion. The lymphangions then propel lymph to the lymph nodes so that's filtered multiple times, and eventually it drains into the angle at the neck back into the venous system. So the pathophysiology of lymphedema then is where there's some kind of disruption in this normal flow, resulting in an accumulation of high protein edema in the interstitial tissues. But what happens when that fluid is kind of trapped in the tissues, where you don't have this good inflow and outflow from the tissues of this lymphatic fluid. Well, we know that at least 50% of blood plasma proteins move into the interstitial space and are taken up by the lymphatics every day. And the primary task of the lymphavascular system, according to Feldy, is to handle the lymphatic protein load. But this lymphatic load, which means substances that must leave the location where they are and can only do so through the lymphatic system, also includes dead cells, bacteria, endotoxins, and enzymes such as MMPs, which can impair wound healing. So what we end up having is this stagnating high protein edema that then develops a pathohistological state of chronic inflammation in the tissues, which triggers infiltration of the tissues by mononuclear cells, resulting in angiogenesis and proliferation of connective tissue, fibrosis, and fibrosclerosis. And that's a direct quote from this textbook. So in a scientific term, it can be described as oxidation and degradation of interstitial proteins attract monocytes that change into macrophages. Macrophages ingest the proteins and activate fibroblasts that in turn form collagen, resulting in connective tissue proliferation. For me as a wound specialist and a lymphedema specialist, I find this quite fascinating because we know that the process of scar tissue formation in wound healing also engages this same process of the macrophages ingesting this dead necrotic tissue and triggering fibroblasts to form collagen to build and fill in that wound with scar tissue matrix in order to heal that wound. So it's almost like this same process that's normal in our body for wound healing has gone awry, and it's just chronically stimulating until you have a massive proliferation of this connective tissue. And this is why it's so important to deal with this underlying pathophysiology and treatment, because if you do not deal with this and the chronic inflammation, you're not going to influence the soft tissue remodeling that needs to happen in order to normalize the patient's health and this process going on. What another reason why it's so important to normalize this process is because this puts the patient at very high risk of recurrent cellulitis. You can imagine not only these proteins that are degrading and causing this sludge in the tissues, if you will, the proteins also now become food for bacteria that are invading our tissues. And what's more, our white blood cells cannot even alert our body that these bacteria are invading us because it can't get to the lymph node where it can trigger an immune response. Therefore, these bacteria have the best place in the world to invade because now they have a nice, warm, dark place to live where nobody knows they're there and they have as much food to eat as they want. And again, this is why it's so important to address all these aspects of care, because we want to minimize the risk of recurrent cellulitis or recurrent wound infections and optimize the patient's ability to heal a wound or normalize the tissue. What is a primary, easy clinical tool to use to diagnose lymphedema? The stemmer test is easy to do. Basically, it is indicative of these changes that are occurring in the tissue when we start having this thickening or fibrotic changes in the tissue. Normally on the top of the foot or the top of the hand, our tissue is very thin and very pliable, and that results in us being able to pinch or tent or squeeze the skin together. However, when lymphedema is present, that tissue becomes thicker and you can't pinch it together like this pictured over here anymore. So if that stemmer sign is positive, and this could be around a wound, it could be on an abdomen, it could be on the foot or the finger, anywhere on the body, if the stemmer test is positive, it means that that patient does have lymphedema. It could be localized lymphedema around the wound, or it could be lymphedema from many different etiologies, but it's a positive indicator of lymphedema. It is never falsely positive, which is amazing because now we can do this very simple test and at least recognize those patients that have already developed this fibrotic tissue. But if it's negative, it does not exclude lymphedema. It doesn't mean that they don't have lymphedema, but perhaps the fluid has not gotten to the point where it's causing this chronic inflammatory process. This can be performed anywhere on the body to be diagnostic of lymphedema in that area. Another clinical feature unique to lymphedema that I want you to be aware of is papillomatosis. Papillomatosis can present as lumpy, bumpy skin with cobblestone appearance, or fibrotic wart-like projection, or even larger knobs, or in some patients it can even be as big as like a cauliflower on the foot. But whenever you see this, be thinking, this patient has an underlying lymphedema or concurrent lymphedema. Look around a wound and look for this lumpy, bumpy tissue, and that will alert you to say, wow, the tissue texture, the tissue consistency is not healthy. We need to be addressing this as part of our wound care. What is gold standard treatment for lymphedema? It is complete decongestive therapy. This includes meticulous skin and nail care, manual lymphatic drainage therapy, multi-layered compression bandaging, which is very customized, especially in the acute decongestive stages, compression day and night, long-term for the rest of their life, therapeutic exercises, patient education, and home program. And even if a patient has very, very advanced lymphedema, like you can see in the picture here, there is hope. Even at that level, CDT can reverse this process, can normalize the tissue, can soften the tissue, can help that lymphatic system to repair, and they can have a much higher quality of life because of it. So in this patient's scenario, going back to this patient, what were the wound care pitfalls? If this patient had been seen in a comprehensive setting, what would the wound care specialists have been recognizing, alerting them to something more needed to be happening with care? There was this missed concurrent diagnosis of lipedema and lymphedema. The Unna is effective for venous leg ulcers if that's all you have, but short stretch multi-layered bandaging is needed for concurrent lymphedema or some alternative that's more robust, has more containment, and it also has to go above the knee. Compression to the knee only resulted in massive localized lymphedema, causing more disability and mobility issues and ultimately devastating this patient's life. Lack of long-term compression resulted in multiple recurrences of venous leg ulcers. And poorly controlled lymphorrhea caused skin denudement and painful partial thickness wounds on an ongoing basis. I remember this patient telling me that at one point she was walking, leaving puddles on the floor, having to keep towels under her leg. The lymphorrhea was so bad, so painful, so disfiguring for her. Even in this is a resource I want you to be aware of. You can download this from www.woundsinternational.com, woundsinternational.com. It's free. The 2015 Venous Leg Ulcer Consensus Document. So in here, it says compression therapy is widely recognized as key to the management of venous leg ulcers. It increases healing rates in comparison with no compression therapy, and after healing reduces recurrence rates. So even if this person was healing with Unna boots in the wound center, there was this failure of thinking about long-term compression, not only from the standpoint of what compression is indicated or most appropriate for this person with lipedema and lymphedema as well as venous leg ulcers, but just for the venous leg ulcers alone. And the recurrence rate is up to 69% if it's not properly managed with compression. What were the lymphedema pitfalls? So this person did see the lymphedema therapist. Now, she may have had constraints based on reimbursement. Maybe this patient allowable was very small number of visits. Maybe this patient had no money for compression garments or bandaging. This is something that we all have to fight for. This is so important that patients have adequate access to care. Why are we failing these patients? Why does everyone else have access to appropriate medical care, but our patients with lymphedema do not? What are some of the lymphedema pitfalls? There was incomplete complete decongestive physiotherapy, and no long-term compression management program. If there's no long-term compression management, the patient's going to be back to square one. There wasn't a lack of intensive manual lymphatic drainage or training in a home manual lymphatic drainage program. Chronic compression below knee only exacerbated and contributed to this massive localized lymphedema in the medial knee congestion zone. Una boots were ineffective for lymphedema, and that was seen in the wound center, and in lieu of difficult thigh bandaging. So we recognize once somebody gets to stage 3 advanced lymphedema, it can be very difficult to bandage. Bandages can slide down. It's just not effective. But they did not utilize alternate compression reduction systems that can be specialized for lobes. So we have to be specialists in a variety of compression options so that we know what will work best for this particular patient's presentation. In this case, this patient did later use a leg assist with a lobule compression system and a leg assist BK with shelf, not only for acute reduction, which gave her the ability and her husband the ability to continually self-adjust to achieve reduction, but also can be used for long-term management. So the interesting thing about this particular system is it has a sling that lifts and compresses these lobules here. Very unique. Not just putting circumferential compression, but lift and compress so that there's lobule reduction in conjunction with leg volume reduction. And you can see that after she started using this, and with appropriate skin care and wound care, she now no longer has recurrent cellulitis, no skin issues, no open wounds, is more mobile, more comfortable. So we have to be aware. We have to become well-versed in the big toolbox of options that we have for patients to make the most appropriate recommendations. Let's look at some of these other aspects of the care. Lymphorrhea. What are some synergies between lymphorrhea with the lymphedema patient or wound care patients? Lymphorrhea is leakage of lymph fluid onto the skin. But guess what? It's very similar to that same fluid that is wound drainage. Both contain these enzymes that denude the skin. Basically, the fluid is in the interstitial tissues, right? If it leaks out of the wound, we document it as wound drainage. If it's absorbed and goes into the lymphatic capillaries, then we call it lymph fluid. So it's all very similar. We know that in wound healing, we have to protect the surrounding skin and manage that drainage effectively, or that's going to cause widening of the wound, painful shallow wounds around our main ulceration. And the same thing happens with lymphorrhea. Anytime there's leaking on the skin, it's going to start eating away the skin and causing very painful superficial wounds. Some of the pitfalls in managing lymphorrhea are that copious or large amounts of lymphorrhea or wound drainage are poorly managed with gauze. You could put 20 layers of gauze on there and it's not going to be the right treatment. It's not going to adequately manage it. Abdominal pads or other dressings without vertical and lateral wicking. So what are some treatment pearls? What can we do? There are a multitude now, thank God, of super absorbent dressings that have quote-unquote diaper technology in them that can absorb and trap very large amounts of fluids. We're talking about even 1 liter of fluid. These are the patients that walk in and are leaving puddles on the floor. We have options for this, whether it's a small amount of drainage. You could use a foam or maybe a hybrid that has a little bit more absorptive capabilities, or you can use these super absorbers. These dressings are very highly specialized. They have vertical and lateral wicking, which means that it draws the fluid into the dressing away from the surface of the skin. So the surface of your dressing should actually be dry, even if you pour half a liter of fluid onto it. And you can test this, just pour water onto it and see how it wicks it into the dressing and the surface stays dry. And lateral wicking means that it moves the fluid, distributes it evenly throughout the dressing. And that's important too, so that you don't get this big bulb of a dressing underneath compression bandaging, because that can cause a pressure area. You want it to be even, you want kind of a low profile, and then as the fluid goes into it, it distributes it evenly. Now, I'm not going to go to this website, but if you don't know about this website, you need to write this down, www.woundsource.com. When you go on there, there's all kinds of information about different types of wounds and very advanced topical wound dressings and treatments, but then it also has dressings as a category, and there's multiple categories. One of those categories is super absorbents, okay? Click on that and you'll see all different options from different companies that you can ask for samples and try these with your patients. They work very well under compression therapy, so this is a huge plus for us when we're working with venous leg ulcers and lymphedema where we need compression. The next problem I want to talk about is intertriginous dermatitis. Intertriginous dermatitis is common anywhere where there is skin-on-skin contact, such as between the fat folds, edematous lobules or toes, or anywhere on the skin, like under the breast, in the creases of the groin. So this is important for general skin care with patients with wounds or with lymphedema. This trapped sweat, bacteria, and excess moisture can lead to superficial skin breakdown and recurrent bacterial or fungal skin infections. This has to be managed, and the patients that have lymphedema often struggle with this because those lobes go very deep and there's skin-on-skin contact. So what can we do? Well, some of the pitfalls are applying topical antibiotic ointments or other petroleum-based products will trap in more moisture and can exacerbate the problem. But what options do we have? Here are some pearls. First, we need to make sure that that skin is carefully washed with hypoallergenic soap and water and patted dry with soft, non-abrasive cloths. These strips of cloths, like there's a product called Biosoft that's almost like a fleece type material that can be cut in strips, or something just very soft that's non-abrasive to the skin. That could be even cut in strips and then used to floss between toes, because often swollen toes have no space between them. It's very hard to get in there and dry that area and keep it, prevent this intertriginous dermatitis and recurrent fungal infections between the toes. Antimicrobial moisture wicking textiles such as Interdry is one brand that's kind of in a category by itself, or absorbent antifungal powders and soft cotton stockinette can be used between the folds. So we may want to use the powders. The Interdry is more like a cloth that goes in between. We can use the powder in combination with stockinette, which is just a tube of soft material that we use as a liner kind of over the limb, but it can be kind of tucked in to create a barrier, skin-to-skin barrier. Now again, a few of these products can be looked up on woundsource.com as well. So go to that website, learn that website, find out what your options are. What are the treatment synergies with chronic wounds? Okay, so every wound care specialist deals with chronic wounds, and often lymphedema therapists are faced with having to treat chronic wounds in conjunction with their therapy. Lymphedema can lead to chronic wounds, and chronic wounds can lead to lymphedema. Lymphedema and chronic wounds need to be treated concurrently for optimal care. You can see in this picture here, this patient has a couple superficial wounds which really are easy to heal. But if you're not dealing with the lymphedema that is surrounding these wounds, you're not going to have good healing potential. That healing rate is going to be very slow. On the flip side, if you recognize here in the picture, this patient has lymphedema. It looks like maybe they bumped their leg on something, so it probably was a traumatic wound now leading to a chronic wound because it's not going to heal well. Very easy to resolve if you understand both problems and treat them together. Some of the pitfalls: lymphedema clinicians are often not confident in treating wounds and rely on the wound center to heal the wound first. However, delaying lymphedema treatment may significantly slow the wound healing. So again, here's another picture. This person has chronic wounds. The health of that wound looks terrible. But if I'm just trying to treat that solely from a wound specialist perspective, I'm not going to have as much success as if I'm treating the lymphedema and wound care together. Now, oftentimes in the clinical setting, these two practices are very segmented. So if a person is not cross-trained, then we have to somehow have better collaboration. Compression typically used for wound care may not be effective for or may even exacerbate the concurrent lymphedema. And we saw this in our patient case scenario. What are the pearls? One of the pearls is early diagnosis of lymphedema, and a collaborative approach to care is needed to improve outcomes. Cross-training optimizes concurrent treatment of chronic wounds and lymphedema. Now, if you haven't noticed already, I am very passionate about this. I'm telling you, this has to happen. We have to improve our collaborative care. We owe it to these wonderful people that happen to have this medical diagnosis that just we are underserving. We are not doing justice to what they deserve. We have to rise to the occasion. What are some other treatment pearls? Adding even modified CDT, including manual lymphatic drainage and compression, whenever stemmer test is positive, is a huge win. Okay, so if we have chronic venous disease and phlebolymphedema, the secondary lymphedema, even from just the knee down, and we do everything that we need to from a venous perspective, just adding some elements of central decongestion and MLD to change the tissue texture and address the secondary lymphedema is critical. Inelastic compression, something as simple as adding night compression for that phlebolymphedema component with a chipped foam liner, because when we're doing lymphedema bandaging, we use custom placement of incongruent bags of foam or layers of foam to help act as a micro massage underneath that compression with movement and help warm and soften and remodel that thickened fibrotic tissue. So just by nature of adding something like that adds compression and soft tissue remodeling, even at night while they're sleeping, would help address this phlebolymphedema. And CDT can help optimize wound healing potential and reduce the risks of recurrent cellulitis and infections when there is a secondary lymphedema component or lymphatic damage. If you would like to learn more about differential diagnosis of lower extremity edemas and lymphedema staging and the clinical signs to recognize right away how to do the stemmer test, we have some wonderful tools for you that are free. Just ask us for them. You can request quality printed copies, high quality on cardstock at www.ILWTI.com. I want to give these to you because they're very useful, not only just to have in the clinic for reference, but to use for cross-education with referral sources or other colleagues that you want to collaborate with. And with that, I thank you for your attention. I'm going to take some questions now. Just give me a moment to change into video mode so I can see you in person. Okay, thank you so much for enjoying this session with us. The first question I'm going to answer is, if a patient has phlebolymphedema with a positive stemmer sign and receives vein procedures to correct the underlying incompetent veins, do they still need CDT? So that's a very important question, because in some cases, if the primary etiology of the secondary lymphedema is primarily related to local lymphatic damage as a result of that venous disease, you may find that treating the venous disease with compression and possibly underlying venous procedures, which are very important for preventing recurrence of venous leg ulcerations, there may be some resolution of that secondary lymphedema. It kind of depends on how far the progression is of the damage to the lymphatics, as well as the development of that fibrotic tissue in the skin. So if the toes are very swollen and very hard, and that lymphedema on the foot is very hard and thickened, then I'm saying that most of the time you're going to have to engage a lymphedema specialist for complete decongestive physiotherapy. That can happen anywhere in the process. It could happen early on in your treatment, which will help you with healing the venous leg ulcer. Or maybe you make that referral and that patient can't get in to see the lymphedema specialist for a period of time. At least keep in mind implementing some night compression with foam, maybe modifying your type of compression you're doing with the wound care to implement layers of short stretch bandages for a little more containment. Use some pre-formed chip pads that might be able to soften areas of fibrotic tissue. Excuse me. And then refer to the lymphedema therapist. The second question. Oh, here we have another question. Why is lymphedema not recognized by insurance or certain medical staff as not necessary or valid to watch out for? Excuse me just for a second here. This is another very important question because I think most of it has to do with lack of education or understanding. I would hope so, because as healthcare professionals, we go into this business to help patients. I think at the heart of every clinician, whether you're a wound specialist, a vascular specialist, lymphedema specialist, a rehab specialist, a nurse, whatever your practice is we do want to help the patients. I think it's just that we don't learn this in medical school. We don't learn it in nursing school. It's probably not really well addressed even in therapy school. So part of it is ignorance, part is not recognizing it, part of it is it hasn't been integrated into clinical practice as well. And so it's not recognized by the clinical practitioner. And we have not bound together to have a strong enough voice with the reimbursement or the payer sources to be able to say, hey, this is inexcusable. This is a valid medical need. And guess what? It's costing you way more money to just ignore it. So this is also why it's so important to be a member and support the Lymphatic Education and Research Network, because this is part of the mission of us all being able to join together to raise the awareness and be that voice, not only patients coming together and persons with lymphedema that are living with this every day becoming stronger and stronger and more empowered with that voice. But we have to do our part as medical professionals and go the extra mile in not only dealing with everyday clinical practice, but also helping be that voice to change reimbursement and demand that this diagnosis be recognized and that adequate care is delivered. How do we address that Medicare covers Viagra but not compression stockings? That's a very good point. Okay, so I'm not sure who has political leverage there or influence, but this is very wrong. Okay, what kind of compression is needed for phlebolymphedema as compared to chronic venous insufficiency? I addressed this a bit. The difference is that chronic venous insufficiency, if you have that diagnosis alone, you need day compression enough to contain a more watery fluid base. And night compression you don't need, because you just need elevation at night and the blood will flow better through the veins, and that helps deal with the venous edema. Phlebolymphedema is a little bit different in that you have the lymphatic component. Elevation is not going to be that effective anymore. Now you have that chronic inflammation, the soft tissue changes, and you're going to have day and night compression, as well as compression that integrates foam components for soft tissue remodeling, and also integrate manual therapy to deal with that protein load that is causing that chronic inflammation. What is the treatment for hemosiderin staining is another question that came in. Hemosiderin staining is just a clinical sign of the venous disease, and which ends up staining the skin. So the treatment is the typical treatment for venous disease, which is compression therapy, looking at the underlying venous dysfunction and considering vein procedures to correct the underlying dysfunction. I have heard in some cases that therapists have tried kinesiotaping on that area. It's not going to resolve the hemosiderin staining, but it may help fade it a bit. What you'll find is that hemosiderin staining that's active, it's going to be more reddish purple, it's going to be darker. Over time, if you have adequate compression therapy and treatment for the venous disease, it will fade over time, but typically not completely going away. What is your experience with dietary intervention as a complementary tool along with the physical therapies and CDT that you do? There's a wonderful book, and I'm trying to see if it's on my shelf right there. It's Nutrition for Lymphedema. You can look that up. It's available on Amazon, and I believe probably on fatdisorders.com and probably on the National Lymphedema Network. So I would refer to the experts with that book and refer to that as far as what kind of nutrition, what kind of things can you do to modify your eating habits, and what kind of foods would be most conducive to lymphedema treatment. Who pays for the materials such as padding, short stretch bandaging, wound dressings, the clinic or the patient, the sniff? That's a really hard question to answer in the context of this webinar, because it does depend on a number of things, which is the practice setting. So in some practices, it may be lumped into the overall reimbursement that practice setting receives, or it may be something that the clinic provides as part of their billing, or it could be the patient or family has to purchase that separately. So as far as I'm looking at the chats and trying to scroll down, it's not scrolling any further. I hope that I got all of the questions. I have tried to be careful about making sure I answered every question that came through. I apologize if I did miss a question. And I hope you really enjoyed this session, and I really appreciate your time in joining me today. And thank you for the opportunity to learn, to be able to share some of my insights and things that I'm passionate about in trying to elevate the care of the treatment of wound care and lymphedema patients. And all of you out there, I know that you wouldn't be attending this seminar if you were not as passionate and dedicated to this practice setting. So thank you, all of you, for your labor of love in our clinical practice on a day-by-day basis. I know sometimes it can be very difficult and you are not necessarily given a pat on the back or thank you. So on behalf of myself, Robin Bjork, and the Lymphatic Education and Research Network, thank you for your service, and thank you for joining today's webinar.